Good afternoon to everybody. Thank you for spending part of the afternoon and tearing yourselves away from this amazing view. I have no disclosures that are relevant to the topic at hand today. There's a few questions that are embedded within the presentation here, so there'll be an opportunity to participate in the live polling, similar to what you guys may have done at other sessions. Obviously, neuroimaging and dementia diagnosis is a very, very broad topic, and my goal today is not to be comprehensive in terms of covering every little imaging finding that may be present. My goal today is more to briefly review available imaging tools and talk through at least one way of using these in the context of dementia differential diagnosis. So the syllabus for this course is going to be much more detailed than what I present today in the presentation. But what I thought would be interesting here was to take the information that was in the syllabus and rather than review it point by point, try to illustrate some of those pieces of information in the context of clinical cases that will hopefully be better in postprandial times here.
Yes, but we just ask if everybody in the back can hear.
Can everyone in the back hear me? Good. All right. With that, let's hop in. So these are just very briefly to introduce some of the types of imaging. So CT scans have been around for quite some time now. They're widely available. They're relatively inexpensive. They're fast, which can often be helpful if your patient has behavioral disturbance. They can be combined with vessel imaging, as we all know, with CT angiography and venography. However, compared to MRI, CT imaging has lower spatial resolution. It's much more difficult to visualize white matter change and be sure of it on a CT scan. And CT scanning is not sensitive for microhemorrhage and less sensitive for trace amounts of sulcal blood. And a little bit later in the talk, we'll see a case of cerebral amyloid angiopathy. And given how common that is, this can be a big concern. MRI imaging, as everyone knows, is a mainstay of neurologic diagnosis and has great utility in the context of dementia differential diagnosis. So it has high spatial resolution. It exploits multiple types of tissue contrast. It can be combined with vessel imaging as well, both with and without contrast. It is sensitive for microhemorrhage using GRE or other types of susceptibility-weighted or T2 star-weighted imaging. We know that it can detect early signs of stroke, so sometimes it's incorporated into stroke protocols, and that's how the information is conveyed back to the behavioral neurologist. Obviously, the patient needs to be MRI compatible in order to do this, and not all patients are, so that can be a disadvantage. So individuals with pacemakers, other implants, at least at the present time, can't get MRIs. The imaging times can be lengthy, and at least for me, this has been a concern, especially in patients with behavioral disturbance, poor memory. Sometimes it can be difficult to explain to them why they're in the scanner, especially for a long period of time, and this can definitely be an issue. Claustrophobia, especially if anxiety is high anyway at baseline, can be an issue. The availability also is a little bit less, especially in emergency room settings as compared to CT, so that can be a concern as well. And because MRI is so important, because looking at structural imaging is, I think, very crucial to dementia differential diagnosis, I thought I'd start off with this figure here. So this is a beautiful study by Cliff Jack's group at Mayo, and what's shown here is a statistical and parametric map showing you regions that show significant atrophy in AD versus controls. This is a unique population actually that developed AD over the course of their imaging study. So we'll look at a couple more images from this in a second. But just to stop here for one moment, you notice that these areas in red, these are the areas that show atrophy, are quite symmetric on both sides of the brain, involve both medial and lateral temporal regions, coming up into lateral parietal regions down here. So quite dense atrophy and fairly symmetric. As I mentioned, these individuals were developed mild dementia over the course of the imaging study, so it was possible to use the retrospectoscope to look back and see how they looked 9 to 18 months prior to dementia diagnosis. And I actually think this is pretty instructive. This is just to show you that this medial temporal lobe atrophy was present at the amnestic MCI stage, so this was 9 to 18 months prior to dementia diagnosis. But much of the lateral temporal coming into the parietal atrophy was less clear at this early stage, and this can certainly be a challenge in clinical settings where we're trying to detect the early signs of disease in some cases and differentiate them from normal aging. So this pattern has been replicated now in a number of different studies. This is a particularly nice one, I think, from Anders Fjell's group. So there's two two things here. First, they're looking at healthy elderly, looking at the normal atrophy, because as we all know, there's atrophy with aging, comparing that to see what is seen in Alzheimer's patients. So I'll draw your attention to the scale bars here. You can see that in order to look at Alzheimer's patients, they actually had to use a scale that was less sensitive, so has a higher range here than what they're using in healthy elderly. You can see that these lateral temporal regions are showing quite a bit of atrophy over time. So this is 2.5%. This is 1 year change. So pretty substantial. And so you can understand how on the prior side you may move from that MCI to the mild dementia stage. Whereas in healthy elderly individuals, the amount of change is less and is more distributed, so less focal. So this has led to the notion that we should be looking visually at medial temporal lobe atrophy, incorporating this into our understanding of whether somebody may have disease or not. And a number of groups, especially Philip Shelton's groups and Giovanni Frazzoni's groups, have been looking at this now for years. And they've been able to show in autopsy-confirmed cases that individuals with Alzheimer's disease actually have more visually recognized atrophy within the medial temporal lobe than individuals with DLB or vascular causes of cognitive impairment. So, this can be very useful, but there are some caveats. And one of the big caveats is that, as we mentioned before, as I mentioned before, there's atrophy also with aging, and that's particularly the case in the hippocampus. So here's a slide from one of Philip Shelton's initial studies on this. And these are individuals who are show progressively more atrophy and get accordingly higher grades according to a visual rating scale. But one thing to notice is that age can also be a factor. So in this figure here, there's two regression lines. So the dotted lines are for individuals with Alzheimer's disease. The solid line are actually for cognitively normal individuals. So this is that same subjective scale score that I was talking about before. So higher is worse here. And as you can see, with aging, even in the normal elderly population, there's quite a lot of atrophy. And this sort of speaks to, I think, 2 points. The first one is that the structural imaging especially, I think, needs to be interpreted in the context of the person's age. So especially in the oldest old, this is a concern and should be taken into account. The other issue is that it may be the case that we really want to also look at other regions and not just the medial temporal lobe, look at the preferential atrophy in places like the posterior cingulate and precuneus, and I'll talk a little bit more about that in a second. This is from a beautiful study by Gil Rabinovich's group at UCSF, and the atrophy patterns that you see in AD are actually differential in some of the AD variants. As you might expect, given the very distinct clinical syndromes that are present, there's also distinct patterns of atrophy that are present. So this is comparing early onset AD to control. So this pattern is pretty similar to what we saw before, perhaps with a little bit of less lateral temporal atrophy in these early onset cases, but nonetheless quite symmetric, involving the NTL, involving the posterior midline, posterior cingulate, and precuneus. In contrast, in logopenic variant PPA, which is another expression of Alzheimer's pathology, you see very left lateralized atrophy patterns, again, more focused presumably on the language networks here, and perhaps a little bit less involvement of the posterior midline. And posterior cortical atrophy, again, another AD variant presentation, also has a somewhat distinct pattern of atrophy shown here in green. So symmetric, perhaps with a little bit later involvement of medial temporal lobe regions, and but also involving the posterior midline, a bit more involvement of occipital and inferior parietal structures as well. So the next major quiver in the neuroimaging toolbox is functional imaging, and probably the most common tool used in that context is FDG PET. This has now become pretty widely available. It's reimbursed by many insurances, especially in the context of differentiating frontotemporal dementia from AD. It potentially addresses a wide differential diagnosis. So you can see there's patterns that distinguish many different conditions with FDG PET. And one important thing I'd just like to stress about FDG PET is that it can reflect underlying structural change. And so I put this as a plus or a minus. So you can imagine that a region that shows profound atrophy would also show profound hypometabolism because there's less structure to give rise to the metabolism that you're visualizing. So in some ways, the FDG PET recapitulates the structural pattern that you might have already seen in your structural imaging. However, this is not necessarily the case. So in conditions, we'll see in a little while, a case of Lewy body dementia with very little associated atrophy, there's still discernible FDG patterns there. So it's not always the case that this is true, but it can be. And so this may mean that if you have a very recognizable syndromic pattern of atrophy, that the utility of FDG PET perhaps might be a little bit less. All PET scans, of course, involve some radiation exposure and are relatively expensive and involve lengthy imaging times, and that can be relevant to which patients you might select for this sort of study. SPECT imaging provides a lot of the same information as FDG PET. It's a little bit older modality. In some contexts, especially in Europe, it can be a little bit less expensive. Also can reflect underlying structural change. It's also a bit more sensitive to vascular changes, and at many centers, at least in the U.S., has been replaced by FDG PET. So the next major class of imaging that I just want to briefly review is molecular imaging, and in the context of dementia differential diagnosis, probably the most talked about molecular imaging tool is amyloid PET. So now I believe there are 4 FDA-approved amyloid imaging agents. So the important thing, there's a couple things about amyloid PET. First, it's early. We're still learning how to integrate this into clinical practice, and I'll talk a little bit about that in a minute. But what amyloid PET does is it provides information on the magnitude and distribution of fibrillar amyloid burden. It does not constitute a diagnosis in and of itself of Alzheimer's disease or anything else. In this context, though, because amyloid is a sine qua non of Alzheimer's disease, because it's required for a definite AD at path, a negative amyloid PET, however, may be greatly useful to reduce post-test probability of Alzheimer's disease. Conversely, a positive amyloid PET may be useful in a context where the background rate in the patient's demographic of incidentally positive amyloid scan is low. It can be very useful in ruling in Alzheimer's pathology as a cause of cognitive impairment. There's definitely a potential for false positives, and part of this is driven by the notion that amyloid itself is an age-related pathology, so the sensitivity and specificity, especially the specificity, may vary somewhat in older individuals. It's an expensive study, so at our center, at last check, which was a week ago, it was $3,200, and many of the scans that were done were paid for out of pocket. That might be changing, however. There's an innovative study, again, led by Dr. Gil Rabinovich called the IDEA study that's examining the utility both to the patient and to the provider of doing amyloid imaging. And so we're going to learn a lot more about how to use amyloid imaging. The study will provide access for about 18,000 individuals to have an amyloid PET, and we really look forward to the results, and we'll be participating at our center. Just to take, again, a broad view, this is looking at differences between controls and early onset AD in terms of FDG PET patterns. So this is at a group level. And you can see there's some similarities to what we looked at before in terms of the atrophy patterns. Quite a lot of similarities, actually, with a lot of lateral parietal involvement as seen here. Along the posterior midline, this is one of the key features of FDG PET that's often used to support a diagnosis of Alzheimer's disease, so hypometabolism along the posterior midline and the posterior cingulate and precuneus. And this definitely outpaces the amount of atrophy. This has now been shown in several studies. In contrast, amyloid PET shows a much more widespread pattern, so it's present even in regions that don't show a lot of atrophy or hypometabolism, including the frontal cortex, and if you look along the midline, there's quite a lot of deposition all along the midline, and I'll show you some sort of patient-centric examples of that. Dopamine PET is also another molecular imaging technique. We tend not to use it very frequently at our center, but there is the possibility of using tracers that are specific for the dopamine transporter or for the dopamine vesicular pool or a dopamine receptor subtype. At our center, it's mainly the dopamine transporter that's imaged. So the information that you get back from a DAT PET doesn't overlap with CSF measures, so it's pretty unique. Has little overlap with structural measures, but it does require experienced readers, so especially in borderline cases, the findings can be somewhat subtle. It's expensive. We've had good experience with getting these studies covered, however, and it doesn't take the place of a dopamine replacement trial. So sometimes if that's part of the workup, this doesn't obviate that need. I'm very briefly going to talk about some emerging technologies. So this is not available on the clinical side at all, but tau PET imaging and the incorporation of tau PET imaging into clinical research has been a really exciting development over the last few years. There's multiple different tracers that are being pushed forward for possible use. The validation is still ongoing for all of these. It's very exciting, but there's still a lot of work to be done, and there's still an open question as to whether and which tau PET ligands will be useful in non-AD tauopathies. This doesn't differentiate, as CSF does, between phospho and non-phospho tau, so that's a consideration as well. Functional MRI is near and dear to my heart, but unfortunately, although it's commonly used in research settings as an AD biomarker, it lacks the standardization and validation that would be needed for clinical use. So I'm not going to talk more about it today. And so, as I said, this is sort of a bit of an experiment, but I thought to illustrate some of the concepts that were in the syllabus, I'd go through some of the cases from my own clinic. Because I'm the clinician working them up, they're imperfect, as you'll see, and in some cases the stories are incomplete. But I think that should perhaps resonate with some of the experiences you may have. So certain patients and families are more or less inclined to have further diagnostic workups. Some do not want that, and sometimes that impacts how we use imaging and when we use imaging. So with that, again, a reminder about the live polling. So I'm going to present this case and then ask you guys what you think. So this is a 61-year-old man with a history of alcohol abuse, depression, who presented to the clinic for 2 to 3 years of questionably progressive short-term memory loss and anomia. So the big issue was that he'd lost his job because he could not learn a new computer system and had poor work performance. He was having difficulty specifically with names and recalling details of recent events. He was heavily reliant on written aids. Screening for depression in this individual was floridly positive, high anxiety and vegetative symptoms. He'd started seeing a psychiatrist and was on increasingly high doses of bupropion. One daughter was very concerned that there was an alcohol relapse, and I got one of those messages that many of you might have gotten in a letter that preceded the appointment, that she felt that this was the case. Other family members weren't quite so sure. At home, he was still actually able to do a lot of things, able to manage finances, medications, no motor symptoms, and no family history of dementia. So his testing in the clinic, so he scored 22 out of 30 points on the MoCA, with 5 points lost for delayed recall. Executive and visuospatial tasks were also mildly impaired. His neurologic exam was normal. The formal neuropsychological testing was pretty similar in pattern to what I described above. So with that information, I'll wake you guys up from lunch by asking you this question. Which diagnosis seems most likely given with the given information? So if you guys could just take a second to weigh in on that with the audience response system. It is?
Not after that.
Okay. That's all right. So, is it not working for people? That's the feedback I'm getting? Okay. Okay. Perhaps that's what I needed to do. Sorry about that. I guess I needed to click and say waiting for votes.
Oh, got so.
Yeah, so because there's a lot to cover, I'm just going to take a look at what we have here. So a lot of people are gravitating towards Alzheimer's disease, but there's just a substantial number of people thinking about depression or pseudo-dementia, with a couple of other things kind of filtering in here, including alcohol-related dementia. And this was very much along the lines of my thinking. I thought Alzheimer's disease was definitely a major consideration, but that other things were possible. And we can see how the imaging may inform this decision. So here's the T1 image, and there's a couple things I'll point out here. First, that the lateral ventricles are widened and somewhat asymmetrically so, a little bit greater on the right than on the left. If you look at the medial temporal lobes, there's definitely atrophy for a 61-year-old. It's present bilaterally, again, maybe a little bit more on the right than on the left. Looking at the sagittal sections for frontal and parietal atrophy, there's definitely some parietal atrophy and I think some frontal atrophy present as well, and you can compare that to what you're seeing in the occipital lobes here. So again, kind of interesting, a little asymmetric, a couple of features that are definitely suggestive of Alzheimer's disease. The FLAIR imaging was as follows. So the question is are there vascular contributions here? So not a lot of white matter disease was present, but there was a stroke that was not symptomatic. The individual didn't know about it. So maybe this was contributing somewhat to his presentation, but perhaps also maybe it was partially responsible for some of the asymmetry that we were seeing on the prior image. You're also seeing some parietal atrophy, including lateral parietal atrophy here in this axial section. So given the MRI here, I'll again take people's opinions on which diagnosis you might think is more likely and see how the MRI may have changed that. So I'll learn my lesson and go to this next slide. Okay, again, very much along the lines of what I would have thought. So Alzheimer's disease, early onset definitely becomes, I think, much higher up on the differential. Depression by itself, I think, comes lower down, and that was very much my thinking as well. So this individual was young, and the family had a great concern about what was going on. The individual wanted to be involved in research, so we're fortunate to have a number of different more bits of imaging on this individual that I'd like to share with you. So these were all done on research protocols, so I did not think that these were clinically necessary, but we have them, so I'll show them. This is the individual's FDG PET, so quite a bit of hypometabolism in the posterior cingulate and precuneus, quite a lot of parietal hypometabolism, including lateral parietal hypometabolism here. So again, in an AD-type pattern. Here's his amyloid PET, which, so I don't show you the SUVR values in this particular case, but you can take my word for it that this is a very, very elevated amyloid burden. So in many different cortical heteromodal association areas, you see elevated signal. So you're seeing that here. It's slightly asymmetric. This may have something to do with because of the stroke that we saw before, perhaps not. And if you look at the temporal lobes, laterally more than medially, consistent with the path literature, you're seeing elevated amyloid burden. Along the midline, this is really striking, at least to me. So there's a lot of amyloid deposition, especially in the posterior cingulate and precuneus, relative sparing of the pre- and post-central gyri here, and again, a lot of amyloid burden along the midline in the frontal regions. So because I have it, I'll show it. This is this individual's tau PET. So this is presumably labeling neurofibrillary tangle pathology. So you can see that there's substantially elevated tau pathology, including along the posterior midline. So again, a work in progress, but certainly an interesting image. So I think we can skip this because we already got to 100% before. And so I will go on to the next case. So this is a 65-year-old woman with no relevant past medical history. Her husband says she has a 1-year history of figuring out visual information. Her husband's main complaint was that her cooking had deteriorated. So he would even help her by taking out all the ingredients, putting them onto the counter, but she was unable to integrate that information, put it together, and actually finish a recipe. So she also was an avid reader and had started to have major difficulty following lines of text on a page. So now she actually just listened to audiobooks. She started to have difficulty with short-term memory 2 or 3 months prior to seeing me. It was quite mild, but the family felt already in that period was progressive. She was still driving, which we talked about, managing medications and doing most household chores. So here's her imaging. So this was from an outside study, so it wasn't protocoled exactly the way I'd like, but this is T2 FLAIR over here. You can see that there's quite a lot of atrophy in the posterior parietal regions, especially laterally. Interestingly, if you look at this coronal section, which isn't the optimal study, but it's a T1 post in this case, if you're looking in the medial temporal lobes, actually there doesn't seem to be a ton of atrophy there. So I think that was an interesting feature of this particular case. Here's her FDG PET. So we're seeing that there is substantial hypometabolism in lateral parietal regions, including inferior lateral parietal regions, and some in the occipital cortex. It's a little bit asymmetric in that there's more hypometabolism on the left rather than the right, so this is not in radiologic convention. And you're seeing that even as you become more inferiorly with the midline structures somewhat preserved, in this case in the primary visual cortex. Up by the posterior midline, you're starting to see some hypometabolism, again, slightly asymmetric. So together, these imaging features and our clinical characteristics made me think that this individual had posterior cortical atrophy. And this is not the same patient. This is from a really excellent review by Crutch and colleagues in Lancet Neurology. This is in the syllabus if you want to see it. So this is an illustrative patient from that study. Again, you're seeing that there's quite a lot of lateral parietal atrophy and posterior cortical atrophy. FDG PET actually looks fairly similar to what we saw, a little bit less asymmetric than in our patient. Again, the amyloid PET, just to remind you, looks quite different in terms of its topography in this particular case. And at a group level, again, this is another study from Gail Rabinovich's group. This is looking at FDG PET and controls versus posterior cortical atrophy. And you can sort of see the pattern of hypometabolism that's present at the group level. So a little bit less involving the medial temporal regions, but still a lot of lateral parietal and even some occipital coming into temporal hypometabolism, and again reinforcing that the pattern is different on amyloid PET on the right. So the next case was an interesting man. He was a 76-year-old individual, former physician with atrial fibrillation. He was on Coumadin for amelioration of stroke risk, who presented with slow decline in memory over the prior 3 years. So he had a clear gradient of short-term versus long-term memory loss. He had preserved language and attention, but he had started to defer financial planning and tasks to his wife, and he started getting lost while driving. So he scored 25 out of 30 on the MoCA with 2 out of 5 delayed recall. I'm not showing the cube, but he was 5 out of 5 with cues. 1 point each on cube, drawing, and orientation. So to start off with, this has the feel of a AD case, perhaps, and this is the structural imaging. So this is T1 imaging, looking at the medial temporal lobes. So again, quite a lot of atrophy, definitely symmetric, or appears to be symmetric, at least in this section here. Looking at the sagittal sections, again, there is some parietal atrophy, not a lot of frontal atrophy, but some posterior midline, posterior cingulate, and precuneus atrophy. So again, sort of consistent with this idea of an Alzheimer's picture. He did have some cardiovascular risk factors, so the question is, how is vascular disease is this contributing here? So this is what his image looked like. So this is T2 flare. So looking at the white matter hyperintensities, so these aren't, people have different ways that they describe these. I think for most people, this would fall into a moderate amount of white matter hyperintensities, so something that could be contributing to his presentation, perhaps along with AD pathology. And there was no sign of this on exam at all, but actually if you look at his susceptibility weighted imaging, you see yet another finding, which is that he had numerous microbleeds that weren't detected by any other imaging. So this by itself meets criteria for a probable cerebral amyloid angiopathy, and so that's certainly a concern, especially since this individual was on Coumadin with increased intracranial hemorrhage risk. So now what do you do? So, of course, what I did was consult with cardiology and my vascular neurology colleagues. The decision after a long discussion was to take him off of Coumadin because of this hemorrhage risk, especially since he had so many microbleeds to start off with. However, of course, this opens him up to increased stroke risk, and unfortunately that's what happened. So about 4 months after stopping Coumadin, he presented to the ER with left hand and arm decreased strength and sensation. Thankfully, these symptoms largely resolved after 4 hours. There was a small amount of reduced strength. He had a head CT that was done at an outside hospital as part of a TPA evaluation, and that was read as negative. The MRI that I'm about to show you was done after he was transferred to the MGH neurology service. So over here is the DWI. I'm not showing you the corresponding ADC maps, but this is an acute stroke here shown by the arrow. So this is perhaps well cited to lead to some of the symptoms that he was having. But interestingly, if you look at his GRE, which was only, so this MRI is only 4 months removed from the one I showed you before, and was actually done on an identical scanner at identical field strength, not the exact same scanner, but the same model and field strength. You're seeing already more microbleeds than were present before, and there was a small lobar hemorrhage that now has some trace sulcal blood that you can see here that was present, even though he wasn't symptomatic from it. There had clearly been changes over time, even though he'd been taken off of Coumadin. So you can see what a difficult decision sometimes this is, what to do with the Coumadin versus Plavix in these individuals. And so I think all learning that cerebral amyloid angiopathy is a common problem. It's thought to be the result of A beta 1 to 40 deposition, so a slightly different type of amyloid that we think accumulates in amyloid plaques in AD. This is depositing in the media and adventitia of small vessels, both in the brain and in the leptomeninges. It predisposes to lobar hemorrhage, and the risk is somewhat proportional to the microbleed burden at baseline. So our patient here with greater than 6 baseline hemorrhages was actually a quite high 3-year risk of bleed, and this was part of the driving thought process behind substituting the Coumadin with Plavix. It's a distinct pathophysiology as compared to hypertensive hemorrhage in subcortical regions, and it can coexist or occur independently of AD. So this is something that we really will see in clinic, even though we don't always recognize it. So of those who die of CAA-related intracranial hypertension, about 50% meet pathologic criteria for AD at autopsy. 15 to 32% of AD patients in memory disorders clinics also meet CAA criteria when they go to autopsy. So this is not an uncommon finding, and this is a great review by two of my colleagues, Anand Viswanathan and Steve Greenberg. Another thing to know about CAA is that it can sometimes have an inflammatory component, and sometimes you see very dramatic signs of flare T2 signal, as shown here. The possibility of inflammatory CAA sometimes warrants consideration of contrast-enhanced MRI, which can be useful to detect this condition. And also, in cases where it's identified, use of immunosuppressive therapies can help resolve these white matter hyperintensities quite dramatically. And again, I'll point you to this paper here, again by Steve Greenberg's group, which discusses how you might select patients both for imaging and for treatment. Okay. So the fourth case is a 74-year-old woman who had a diagnosis of AD, but her family brought her in for a second opinion. And her behavioral state was characterized by both short-term and long-term memory deficits, substantial anomia, but also a lot of behavioral change. So accompanying these memory changes were short-term anger, short temper, anger outbursts, and some somewhat risky behaviors. She was increasingly gregarious. She was spending money at a greatly increased rate. She was drinking more, and she was staying out to all hours. So this was an exaggeration of her otherwise colorful personality, and the family was quite concerned. So here's her structural imaging, which I think is pretty dramatic. So if you look at the left temporal lobes, there's a striking atrophy that's present both medially and laterally. There is some on the opposite side as well, but it seems to be quite asymmetric on the left. And if you look at it in sagittal section, it's really, I think, pretty striking in the most anterior portions of the temporal lobe how much atrophy there really is. So along the temporal pole structures, including the amygdala, entorhinal, perirhinal cortices, all heavily atrophied. And looking at the axial T1, there is also some parietal atrophy that's present. Again, slightly asymmetric, a little bit worse on the left than on the right. So taking this into account, this might push you a little bit more in terms of considering Alzheimer's disease as a possible diagnosis, although the behavioral manifestations are a little bit atypical. So this is one of those cases in which I had a long conversation with the family and said, okay, you know, I think that behavioral variant frontotemporal dementia is a reasonable diagnosis, a working diagnosis here. Alzheimer's disease is possible. She didn't have a very well fleshed out family history, but there was some family history of dementia. So the family thus far has not wanted, and the patient has not wanted any further imaging. So that's where this case was left. So it would be very interesting to see amyloid imaging in this individual, to see CSF studies to better support that diagnosis, but it wasn't possible in this case. So the next case is a 65-year-old woman with what was called early macular degeneration. She had some difficulty with name and word recall. This was pretty mild initially, but had been progressive. And she told me that she would study names before before going out, so she would remember them. So she recounted a story of going to her high school reunion and sitting with her yearbook and trying to remember all the names before going out. And it didn't help. She carried around a pocket dictionary as well, which I thought was interesting. She had difficulty recognizing people that she saw infrequently, but was usually able to recognize people's names if there were people that she saw frequently. She was unable to come up with specific words when trying to express herself. And overall, actually, her comprehension was quite well preserved. She was able to manage a household independently, manage her own finances largely, and was able to do many things, including volunteer at a local senior center. She'd had an extensive workup before I saw her, including CSF that was not particularly consistent with an AD profile, so that's shown here. She'd had a negative amyloid PET, and I had the report, but I don't have the images to show you because I've never been able to get them. For what it's worth, she's not a carrier for the E4 risk allele of ApoE4. She'd had documented serial neurologic exams for 3+ years. These prior notes didn't really indicate what the cause of her cognitive impairment was, and her screening testing, she had a blessed of 0 and a MoCA of 28. So 1 point lost for phonemic fluency and 1 point for delayed recall. So not particularly impaired, at least by these studies, but a very striking story and a lot of work up to start off with. So here's her imaging. So again, I think a pretty striking image. Pretty asymmetric atrophy of the left temporal region, preferentially over the right, although there's atrophy on both sides. This is a relatively young person. And we'll look at this a couple different ways. So here are the sagittal sections. So just compare the left and the right side, and I think it's pretty striking how much more atrophy there is on the left, again with an anterior predominance, but I think a really striking, and sometimes in the literature referred to as a knife's edge type atrophy. So this is a blow up of that same image. So putting this together with her clinical presentation, my diagnosis here was of likely semantic dementia, so an FTD presentation. So this can present in both left-sided and right-sided atrophy syndromes where it's preferential on the left versus right. The behavioral manifestations, as I think many people in the room may know, are different from these. So I point you to this wonderful review by Hodges and Patterson. So this isn't the patient that I saw, but it looks very, very similar if you can think back to the imaging that we saw a few slides ago, including atrophy of the entorhinal and perirhinal cortices. That's very dramatic. The sixth case was a 65-year-old man.
Jasmine, sorry to interrupt for a moment. So the Academy has set up an overflow space with seating. Should anyone wish to remove to that, you'll be able to hear and see everything. You won't be physically in the presentation room, but everything else will be set up for you. And if you just step outside the door, there are escalators, and go up the escalator, and that's where it's not in a room, but it's set up in an open space for people, so you don't have to stand. So if people are interested in that, just come out here to this escalator, and someone will help get you oriented. Sorry to interrupt.
No, not at all. So again, to return to the case, a 65-year-old individual with a medical history of Waldenstrom's, prostate cancer, SVTs, who was presenting for 3 years of poor memory and slowed movements. So his wife described a clear loss of short-term memory over the past 3 years that had been slowly progressive, that he was increasingly apathetic, quieter than in the past, with prominent psychomotor slowing, so both in thought and in movement. He had substantial orthostatic symptoms, so dizziness while changing position was a big problem for him. And he had some sleep disturbance that was not well described, but in the notes that I had was referred to as myoclonus during sleep. So here was his structural imaging. And actually, what's notable here is perhaps notable for what's not here, which is a lot of atrophy. So looking at the temporal lobe structures, you can squint and maybe see a little bit of temporal atrophy, perhaps a little bit of parietal atrophy. But my take on this was that there wasn't a substantial amount of atrophy present. And overall, my thinking, given the clinical symptomology, was that this perhaps could be a case of dementia with Lewy bodies. And we've already seen this panel before. This is looking at AD versus controls, again, from a really nice set of studies by Cliff Jack's group at Mayo. And so this is the AD versus controls that we saw before. And this is just to show you that in dementia with Lewy bodies, there's not always a clear and consistent pattern of atrophy that's seen. And so this is perhaps not surprising given the likely differential diagnosis of dementia with Lewy bodies and the clinical presentation and the imaging with no atrophy. One thing that's important to note, however, is that dementia with Lewy bodies often coexists with AD, so there can certainly be atrophy. Sometimes it's an AD pattern of atrophy that can feed in as well. So here was his FDG PET, and actually has some interesting findings. This is not projecting as well as I'd like, but there is a substantial amount of lateral parietal, and it's not that well shown here, but some occipital hypometabolism as well. So this can be a finding in dementia with Lewy bodies. There's relatively preserved metabolism along the posterior midline, so that would be unusual in an AD presentation, but it was present here. And his dopamine transporter imaging is shown here. So this is a slide from Steve Gompertz. And this is just to show you that dopamine transporter density doesn't change so much with normal aging or AD, but it's profoundly decreased in Parkinson's disease and dementia with Lewy bodies. This is our patient here. And again, this is one of those somewhat subtle scans. So this was read as reduced striatal dopamine binding. So that's shown down here. So this particular case, this individual, about a year afterwards, started to develop some of the visual symptoms that we may associate with dementia with Lewy bodies, and had increasing sleep disturbance that was suggestive of synucleinopathy. He also developed really severe orthostatic symptoms, almost reminiscent in some ways of MSA-A. So this case is ongoing, hasn't come to autopsy, so I can't tell you for sure, but it has the strong flavor of a synucleinopathy. The last case I'm going to show you is a 65-year-old man with a history of coronary artery disease, a lot of medical comorbidities. So he'd had a CABG already, even though he was quite young. He had brittle diabetes. He had 2 years of questionably progressive inattention and poor memory. So he had multiple TIA-like episodes. His EEG had been checked and was unremarkable. He had OSA but was untreated. He had substantial psychomotor slowing, but his answers were interesting. They were actually quite accurate, although very slow. He was pretty slow to respond. His difficulty in attention was sufficient that it actually caused him to move to assisted living because his ability to manage his own diabetes medications was so poor that he was having multiple admissions for ketoacidosis. He had no family history of diagnosed dementia, but his sister had memory complaints, but she also had a history of drug abuse. So here was his imaging, so quite dramatic white matter, confluent white matter hyperintensities. We can see here that along both ventricles, anteriorly and posteriorly, there's substantial atrophy, but also these very confluent white matter lesions here. And white matter hyperintensities, as I sort of referred to before, are not things that are always consistently described in imaging reports. And I think this is one of those contexts, also with atrophy, where it's really useful to look at the imaging yourself in the context of the patient who's in front of you, because sometimes it can inform your thinking. So this is pretty severe white matter disease. There's several different scales that are out there in the literature for grading white matter disease. So this is one of the more common ones from Fazekas and colleagues. So the grade is 1, 2, or 3, and as you can see, our patient is well above Fazekas 3 here. So in this context, I did think that white matter hyperintensities were sufficient to make me think about vascular disease as a cause of his syndrome. So I believe that this patient has what we call a vascular cause of cognitive impairment. Now, another thing to think about, this particular patient did not have a robust family history, but if he had of this sort of thing, we might think about testing for CADASIL or other similar disease entities, and that's talked about a little bit in the syllabus. Another interesting thing was that he had pretty slow progression over time. A little bit later, I found that he'd had formal neuropsych testing actually done twice before, and there'd been little change over time. And I just thought I'd throw this up here because I found it interesting, which was, this is from a review by Giovanni Frazzoni and colleagues, looking at change in a global measure of cognition. In this case, it's just the MMSE score in individuals that are aging normally versus those who are aging with severe white matter lesions. And these are the individuals with Alzheimer's disease. And you can see that although there is a downward trajectory, it's not nearly as pronounced as you see in Alzheimer's disease. So perhaps this isn't that unusual. So a couple of take-home messages. Obviously, there's many different things you can cover when talking about neuroimaging and dementia. It's a very robust and vibrant research field right now, so these are just my opinions on this. I think that imaging is not a substitute for neurological or neuropsychological assessment. I think it works best when there's already a differential diagnosis in mind, so it can make your own thoughts about what's likely or unlikely more or less certain. Structural imaging with MRI, if possible, is a good place to start and is indeed front and center in both U.S. and European guidelines for dementia evaluations. I think patterns of atrophy and white matter disease burden are not always well described in reports, and it's worthwhile looking at your own images in the context of the patient that you're seeing and or reviewing them with radiology. Laterality, magnitude, and preferentiality of atrophy in one region or another can be an important aid to diagnosis, especially when you're looking at individuals who are at extremes of ages. Those patterns can be, I think, really helpful. Cerebral amyloid angiopathy is common and has treatment implications. Functional imaging, to me anyway, is most useful when a clear pattern of atrophy is not present. So, for instance, in the Lewy body case we saw earlier, there was clear FTG findings, but not a lot of structural findings. The use of amyloid imaging is definitely a work in progress, and we'll learn more about how to use this effectively, and perhaps there'll be fewer boundaries in the future to getting these sort of studies on our patients. Right now, I think to me, it's actually quite useful. Amyloid imaging is in young patients in which there may be other causes of cognitive decline, in which in that demographic also there's a lower background incidence of amyloid positivity. So the contrast is better, I think, in young patients. And also as a rule-out study in older patients. So if an amyloid PET is negative, I think that argues pretty strongly against AD as an underlying diagnosis. And again, all of these imaging measures, atrophy, white matter disease, amyloid burden, and hypometabolism can be affected by age. So it's just important to take that into account. And with that, I will thank you for your attention and thank Dr. Morris for arranging this study and for you guys for being here.